This is a session dedicated to innovations in perioperative pain management. And in 1993, American sociologist George Ritzer described what he called the McDonaldization of our society. And according to this theory, people adapt the characteristics of a fast food restaurant to our society. What we want is the contrary. We are here at the country, Italy, the country of slow food restaurants. And what we want is personalization of our treatment to the patients. So if we consider that the hypnotics, analgesics, and muscle relaxants are the three most important components of anesthesia, in the 70s, the group of Ali Hassan in Boston described for the first time the use of train of four for controlling muscle relaxation. And then in the 90s, for hypnosis, the deepness of anesthesia, starting using the BIS, the bispectral index. We were lacking a monitor for analgesia. So, because the sensation of pain is a characteristic for the awake persons, we cannot know whether our patient have pain during the operation. And then the idea of nociception was described. So this is a session on innovation, and we will describe these new modalities we have in order to control nociception during the operation. So I would like to present our first speaker, Professor Esther Pogatzki-Zahn. She's Professor of Anesthesia and Pain Management and Head of Acute Pain Services at the University Hospital in Muenster in Germany. And the title of the presentation is Key Challenges in Perioperative Pain Management. Please.
Thank you so much for the introduction. Thanks for putting up this very important symposium dedicated to personalized pain management. I very much appreciate that, and I would like to present a little bit background and evidence about why this is very important for the future. So the conflict of interest declaration here from my side, and I would like to start with very, very old data, showing you that from different countries and different time frames, starting in 1995, going up to 2015, basically, there are many patients suffering from post-surgical pain. More than 30% of patients have moderate to severe pain intensity ratings, meaning that this is too much for us, basically, as anesthesiologists, watching this patient. So we have to do something, and there have not been many changes related to these issues. And there is, in the recent past, one other issue coming to this, which is chronic post-surgical pain. So about 10 to 30% of patients, 3 months or 6 months after surgery, ask for pain, say, yes, I still have pain after surgery and I had no pain before surgery. And this relates, and I will show you some data, to acute pain and acute pain management in the perioperative period. And last but not least, and this is a topic of the last 5 years, and it comes from the US, but it's in Europe a little different, but not much, and we do not have so many data about that, but many patients take opioids 6 to 12 months after surgery. And we need to figure out why, and this is one aspect. It's very individualized that we are talking about today. We did a very large study that was led by Dominic Fletcher from France, but it involved more than 20 hospitals in Europe and more than 2,000 patients. In fact, 3,000 patients initially have been included in this study. And from these patients all over Europe, 30% of patients, again, said they develop chronic pain after surgery. 30% 6 months, and even 25 to 30% 12 months after surgery. So in Europe, we have the same or similar problems than everywhere, and we have to check what is behind that. And one aspect we already know exactly from this study. Asking the patient very early after surgery, it looks like that those patients that experience pain within the 24 hours after surgery, most develop the highest risk for chronic pain after surgery. As you mentioned, we are able to ask the patients after surgery, but we have no idea what happens during surgery. So this is basically a black box, and we do not know if during surgery, nociception leads to chronification of pain. And so severe pain after surgery, as well as the type of surgical procedure, seems to be related to the development of acute pain, high acute pain, and chronic post-surgical pain. And I show you some data. These are not very new data, but these are the biggest data from Europe, showing you that we have some surgical procedures that produce higher pain scores than other surgical procedures, and these are data from 50,000 data sets from European patients. And here it is important to realize that not only the high-impact surgeries, like big back surgeries or some orthopedic surgical procedures produce pain. Some lower, minor, or moderate surgical procedures produce some pain as well, like tonsillectomy, cholecystectomy, or other surgical procedures. So we have not to put our effort only in the high-impact surgeries, but also in the low-impact surgeries. What we are doing as anesthesiologists, we are trying to reduce pain after surgery by, of course, using opioids. We cannot avoid at all opioids. We try to reduce opioids, but some opioids are still needed. But we can avoid opioids if we use regional anesthesia techniques. And this has been shown in many, many studies that, of course, this is one technique that reduces acute pain after surgery, and we know from nowadays that it reduces the risk of chronic pain after surgery. And these are, again, data from the European data supporting that. However, looking at just one surgical procedure, 150 patients. As I show you here, the median pain score is okay by having acute pain 6 hours after surgery with a 5 or 50 out of 0 to 100, going down after surgery, the days after surgery. This looks not too bad, but looking behind that, every individual patient has their own pain intensity score. And why are these patients here not as good as the other patients down below? This is one very, very important question, and we are not entirely sure what are the risk factors and why these patients develop more pain, acute pain here in this case, than others. And we have tried to figure that out with some large databases again. This is another European study, Pain Out, where we have looked into risk factors for high acute pain scores. And we identified, and it looks very weird, the next slide, so just to show you, and this is the conclusion, that we found 3 major risk factors. One is preoperative chronic pain, so the patient going into surgery already with pain. The next one is young age, and the third one is female gender. These 3 basically independent factors are unrelated to the surgical procedure, always a risk factor for high pain intensity scores. And we try to develop a risk score based on this, and we did this again with another cohort of patients, again 50,000 data sets. We found the same risk factors. In addition, we found preoperative opioids as another risk factor, and we developed this risk score. As you can see, the risk score is predicting acute pain after surgery, but we are missing something because the prediction is only moderate. So still, we have the individual patient. We have to follow up during and after surgery for pain management and good pain management. And one group from the US used the European data again and just analyzed for back surgery. Back surgery is a very painful surgical procedure. And they used 1,000 data sets and again did a prediction. And they not only used preoperative data, they used the intraoperative and the postoperative data. And I would like to point out that here, as shown by the cycles, red cycles are risk factors, blue cycles are preventive factors, that we have intraoperative prediction factors increasing, red, decreasing, blue, the risk of developing acute pain after surgery. And again, and this is not surprising, but this is to be realized, intraoperative non-opioid analgesics, we know that they reduce nociception, they reduce opioid consumption, are protective factors, and that opioids in the recovery room increase the risk. So we have some factors we can change in our daily life for individual patients to reduce the risk of these patients developing acute and chronic pain. And they again developed this risk factor. They had a training cohort and a validation cohort. And again, the predictive factors are there, but they are not as good as individualizing during and after surgery our management for analgesia and for pain management after surgery. So, to conclude, we have risk factors for acute pain after surgery. Every patient is different, every surgery is different, but we have some risk factors related to the surgical procedure as well. We have some protective factors, and just to mention to you, for chronic pain after surgery is even more difficult. We put that here together in a review article very recently. The risk factors for chronic pain are much more complex and probably multimodal. I will not go through this at all, but we have no risk factor yet, and this has been published earlier this year, trying to predict chronic pain after surgery. So the general conclusion here, we have a problem with acute pain management and of course prevention of chronic pain after surgery. More than 30% of patients develop too high pain scores after surgery. 10 to 30% of patients develop chronic pain after surgery. We have identified in many studies risk factors for severe acute pain. They relate to the surgical procedure, but they relate to the individual patient as well, and they relate to what we do with the patient during and after surgery. So I thank you very much for attention and would be delighted to listen to the next talks to hear something about how we can handle this individual patients much more precisely. Thank you very much.
Thank you. Thank you very much. We will leave the questions for the end, and now I want to present our next speaker, Dr. Sean Coeckelenbergh. He's an anesthetist at the Hopital Paul-Brousse in Paris, France, and the title of the presentation is Improving Patient Care by Personalizing Anesthesia. Please.
Thank you very much. Thank you, Esther, for a very interesting talk on a very important topic in today's perioperative medicine. My name is Coeckelenbergh, and I work in Paul-Brousse, and indeed I will be talking about improving patient care by personalizing anesthesia with a focus on the null. Now, I have a few potential conflicts of interest. Please keep this in mind during the talk, and I would like to particularly thank Medtronic for inviting me today. Anti-nociception is important. Too often, we find ourselves here, like Esther said, with either patients that receive too much anti-nociception or those that receive not enough and are at risk of developing complications due to this, most notably excessive pain, even chronic pain. Well, we should be here where patients get up quickly after the operation and have a positive outlook on their perioperative care. Now, how is anesthesia monitored today? In a survey we published just last year that focused mainly on European academic centers, we saw that there are considerable differences in perspectives and use of anti-nociceptive and anesthetic monitoring, despite many clinicians considering it useful to improve outcome. So we find ourselves in a situation of high variability in monitoring anesthesia depth and anti-nociception, despite it being considered by many to be useful to improve outcome. Why is there such variability? Is it due to differences in experience? Is it due to doubt and evidence? What I would like to do today is to show you the evidence for the null and maybe give you a small push towards increasing your experience with this monitor. Now, nociception can be defined as the detection, transduction, and transmission of a nauseous stimulus that elicits an autonomic response even in unconscious subjects. The response overall is sympathetic stimulation, and it gives us a way to objectively measure actually the patient's response to a nauseous stimulus. Classically, what we use is heart rate and blood pressure, but these signs are not sensitive and specific to anti-nociception or anesthetic depth. A lot of things can affect it. Over the past couple of decades, several groups have developed very interesting monitors that elegantly look at autonomic response to nociception. Let's focus today on the null. Now, the null ranges from 0 to 100 and is based on the nonlinear combination of nociceptive-related physiological variables. It contains both hemodynamically derived and non-hemodynamically derived indicators of autonomic response. And what it does is it measures autonomic tonus as a surrogate to NAN balance. One of the first studies that came out with the null showed that during nauseous stimuli in anesthetized patients, there was consistently higher sensitivity and specificity for the null when compared to other indicators of nociception. In a similar study published in 2000 in Anesthesiology, they showed the same thing. They added the tetanic stimulus, but overall, again, the null index outperformed other indicators of nociception with a higher area under the curve. In Montreal, Philippe Richeb's team had another very interesting study, where this time they looked at the effect of increasing remifentanil concentrations when applying the same nauseous stimulus. So they applied tetanic stimulation, and they looked at how the null index changed when we increased remifentanil concentration. And what happened was extremely important in validating a monitor. The null index noticed this anti-nociceptive effect, and the signal decreased with increasing remifentanil. They did a similar study where they topped up or didn't top up an epidural. And again, if the epidural is topped up, the null index is lower, indicating again that this monitor detects anti-nociception. We also looked a little bit at what can happen to the null index when we add another drug. In our study that we undertook in Brussels, we added dexmedetomidine. So both groups had TCI propofol remifentanil anesthesia, and one group received dexmedetomidine, the other one received a placebo. And we found that the null index and the frontal EEG noticed the synergistic effects of dexmedetomidine and allowed us to administer less remifentanil and less propofol. Now, Meyer in 2019, with her colleagues, published a very groundbreaking study, in my opinion, on the null index. Again, they used propofol, remifentanil TCI, guided by the null and the BIS, and they found that you could decrease the amount of remifentanil you administer. So that's already an interesting outcome. But more interestingly, they showed that they decreased the incidence of hypotension, and not just any kind of hypotension, major hypotension with blood pressure below 55 millimeters of mercury. Now, let's go on a small tangent because hypotension is dangerous. Now, I think we can all agree that there is no fixed definition and that probably a personalized threshold for hypotension would be the best goal, but we can all agree that too low a blood pressure is bad. And what is one of the main causes of hypotension in the anesthetized patients? Well, it's the drugs we give. And you can see in a very interesting study, and there are probably hundreds of studies like this, that show that with increasing depth of hypotension and increasing time, patients are at risk of developing acute kidney injury and acute myocardial injury, both of which have been associated, of course, with increased morbidity and mortality. So is NOL a possible solution? Well, perhaps, at least part of the solution, by personalizing anti-nociception to maintain autonomic tonus. Now, how do we do this? It's simple. You maintain the NOL and target. What Meyer and colleagues did during remifentanil anesthesia was to maintain the NOL between 10 and 25. So what they did is they personalized NOL anti-nociception, decreased remifentanil, decreased sympatholysis, individualized autonomic tonus, which led to a decreased use of vasopressors and a decreased incidence of hypotension. As you can see, again, this threshold of 55 millimeters of mercury was significant. This threshold that has time after time after time been shown to be linked to increased morbidity. So that's already an important point. But Meyer and her colleagues went even further. They then published a study in the BGA that showed that when you personalized anti-nociception, fentanyl anti-nociception with the NOL by giving fentanyl to keep the NOL under 25 and personalized sevoflurane with the BIS, they were able to, in a cohort of laparoscopic and robotic surgery patients that were receiving only opioid-based anti-nociception with a morphine or pyritramid and acetaminophen transition, they were able to show this very interesting data. Now, the first thing you need to see is that there's really no difference in the mean amounts of fentanyl. And there wasn't, statistically. But there is a big difference in this figure between the two groups. Can you see it? Can you see that the standard deviation here is much smaller than there? What does this mean? We have similar intraoperative needs, but higher standard deviation in the NOR group. What is the potential impact? What they did is they personalized care to include the outliers. In the control group, they almost always gave the same amount. But in the NOR group, patients that didn't need that much fentanyl had less, and those that needed more had more. And what was the consequence? In their study, they showed that patients woke up more comfortably in the NOR group. By targeting outliers, the NOR led to improved postoperative comfort and a better perioperative experience. Now, will personalizing anti-nociception with the NOR improve outcome? Probably, if it leads to improved hemodynamics and improved patient comfort. But we still need future large outcome studies in homogeneous groups that look for a specific outcome, and thus multi-center randomized controlled trials. Now, I've talked about having a reactive approach with the NOR index, but can we actually predict anti-nociception? Could we move from reactive to predictive? Well, if we want to ask ourselves this question, we first need to accept that each patient, like Esther said, is different. A response to a nauseous stimulus can vary. So what we need is we need the same stimulus for everyone and assess their reaction. And what better stimulus than tetanic stimulation, which is easily available in every OR because we use it for assessment of neuromuscular blockade, and it has been shown time after time to be safe and to correspond to a standardized nauseous stimulus. So already 3 years ago, our team presented an abstract here in neuroanesthesia that discussed this concept in its initial phases. Our aim was to determine if the response to a standard stimulus can predict optimal anti-nociception for incision. And the strategy was to analyze the NOR index change to tetanic stimulation. The population was purposefully heterogeneous to include both cardiac and non-cardiac patients, principally thyroid surgery patients, so that we could have a large range of remifentanil effect site concentrations, and the outcome was incision hemodynamic stability, defined for blood pressure as a value within 20% of baseline, and for heart rate, tachycardia was defined as 20% over baseline, and bradycardia as under 40 beats per minute. So patients were under propofol remifentanil TCI anesthesia. We set the remifentanil effect site concentration to 4 and kept the BIS between 40 and 60. We applied a tetanic stimulation and assessed it. If the normal change was greater than 20, we increased the effect site concentration and repeated. If it was less than 20, we decreased the effect site concentration and repeated. What we wanted was to have the lowest effect site concentration for no change over 20. And this is what we used to incise. And we found that, interestingly, heart rate came back to baseline values without any incidence of hypertension. Now, in the non-cardiac group, there were 2 patients that had a slight increase in heart rate, but of these 2 patients, the highest heart rate was 72. Furthermore, we found that there was a linear relationship between the change in NORL and the optimal remifentanil effect site concentration. This is the formula that's slightly rounded up to facilitate its use. So, the change in NORL index has a linear relationship, or more or less linear relationship, with remifentanil requirements and incision. Is there room for improvement? Well, what if we just do one tetanic stimulation? Could we use this linear regression model to give us an idea? So we tried it. We applied again a tetanic stimulation, measured the change in NORL, plugged and chugged the change in NORL into the derived formula, and incised at that effect site concentration. And we found, again, very interesting information. First of all, we found that blood pressure returned to baseline in almost every patient. One patient had an increase of 21.5%. Okay, it's not perfect. We passed the 20% threshold, but it's not huge either. But very interestingly, and this is might be because we rounded up the formula just a little bit, we have heart rate that remains lower than baseline without any incidence of bradycardia. And in cardiac surgery patients, this could be actually cardioprotective. And again, we showed what's been shown time after time after time with the NORL index, that the NORL index has a higher area under the curve than other indicators such as heart rate and blood pressure or even the BIS for detecting nauseous stimuli. Now, can this work during cardiovascular surgery? That's the real question. So we designed a randomized control trial of 48 patients in all. And we had one group that was NORL guided, where we predicted the effect site concentration for incision, and then we titrated based on the NORL. And another group that had anti-nociception guided by clinical practice. The clinician could increase or decrease anesthesia based on heart rate and blood pressure modifications. Now, what's really important to know, since we had moderate to high-risk patients, we had a goal-directed hemodynamic therapy strategy in place. We wanted to keep the blood pressure and target within 20%, and we kept the stroke volume variation under 13%. So we applied a goal-directed hemodynamic therapy. We guided remifentanil with the NORL, and we found that, again, we can administer less remifentanil when we guide with the NORL. But we also found some other interesting data, which, needs to be thought over quite a bit in its interpretation. But it's very interesting. First of all, the mean arterial pressure was not different between group, contrary to Meyer's anesthesiology study. But again, don't forget, we were administering norepinephrine to maintain blood pressure within 20% from the get-go of baseline values. However, we also have this. We have heart rate that seems to be better controlled in the NORL group. As you can see, the median is lower. They don't have as much increase in heart rate. And the BIS is also more in target. In the control group, there was more overshooting and decrease in BIS. Very interesting, because we administered less remifentanil in the null group. So despite administering less remifentanil, heart rate is more tightly controlled, and this is more in target. Why did this occur? Now, this is only a hypothesis, but I think, perhaps, that is because we administered the right amount of remifentanil at the right time. Instead of having to catch up after, for example, nauseous response and increases in heart rate, and then increasing both remifentanil and propofol, which would have led to decreased BIS, we started with a good effect site concentration and were able to maintain anesthesia in a more stable state. Now, does the null have limitations? Well, of course, like anything in life, and like all monitors, there are limitations. For example, you can have loss of signal and you have to readjust your finger probe. For example, in this randomized controlled trial, we had about 5% of missing null values in the interventional group. In the control group, which was blinded, we had almost 20%. So you need to keep this in mind when you use it. If the null doesn't say anything, you need to adjust maybe the electrodes, maybe even change them. What about hemodynamic variables? Like I said, one of the main things that the null uses is hemodynamic response. So if you do something like an alveolar recruitment maneuver, and you increase thorax pressure, and you chase blood out of the thorax and modify heart rate, you might have a change in null. Does it mean that the patient needs more remifentanil? No, it just means that we have an acute hemodynamic event. You need to be cognizant of this. And of course, arrhythmia. Arrhythmia, unfortunately, the null, at least today, is not reliable when there is arrhythmia. Now, what are the future directions? Well, again, like I said earlier, prospective randomized controlled trials. And what about integrating nauseous stimuli into the null platform? Wouldn't it be nice if the null could tell you how much remifentanil you need before the surgeon incises? So in conclusion, I would like you all to go home with the following messages. Despite views and evidence that anti-nociception monitoring can improve patient care, there is still high variability in clinical implementation. The null index is a reliable tool to assess nociception anti-nociception balance intraoperatively. Why don't you give it a try? And future studies should continue to investigate the potential of personalizing anesthesia to improve patient care and comfort. Thank you very much.
Thank you very much, Dr. Coeckelenbergh. And now I'll present the last speaker for today, Dr. Marco Rispoli, from the Department of Anesthesia and Intensive Care at the Monaldi Hospital in Napoli, Italy. And the title is Implementing Null Monitoring in Clinical Practice. Please.
Thank you. I'm going to talk about the implementation of null in our clinical practice, because we talked about the room for improvement in postoperative analgesia. We talk about the proper monitor to control our analgesia, but something still doesn't work. Why clinicians are used to monitor hypnosis and curarization? Because we are afraid about consequences for the awareness and for the postoperative residual curarization. What about analgesia? Why we don't measure it? Because if we cannot measure it, we for sure cannot manage it. Is it a problem of technology? Maybe the monitor we can use are not still good as we prefer, or it's a problem of culture. Maybe it's a matter of technology. We can think about the postoperative residual curarization. This is the paper per year that have some linear correlation with the diffusion of train-of-4 watch technology. So the problem arises when the technology is the right one to locate it and to highlight the problem. But it's not so easy. It's not only up to technology innovation. Gutenberg invented the printing in 1448. It was a technological innovation. But before a real revolution, we have to wait for the change of mentality, just several centuries after the innovation. So it's not always up to technology, but we have to be ready and prepared to receive that technology. This is an interesting paper talking about the decision-making in postoperative analgesia. I used to talk about safety, decision-making in patient safety. There are a lot of bias while we are managing our intraoperative and intraoperative analgesia. This is the one most surprising, the overconfidence bias. When we use local anesthetic to perform a block, our patient more probably will receive an underdosage of opioid because we are too confident. And this is an example of how we are not ready for a real revolution, or how we have to change our culture before to understand the nociception, because there is an inverse trend when it's up to nociception. We talk a lot about nociception, but we don't talk enough about how to monitor nociception and how this can help us in clinical routine. Maybe it's a matter of mentality, because one of the limits of introduction and implementation of nociception monitor in our routinary practice is that clinicians want the magic number. This is pain, this is not pain. But you have to understand what is behind the nociception. Otherwise, it will not work for you. And the problem is that medical literature still has to face evidence not so strong, a conflict of interest, small sample size. So the sensation, feeling is, I'm not sure if it does not work or there's something to it, because we talk about nociception. I think that definitely something to it, and I'm going to show you how the null monitoring in my routinary clinical practice gave some hint and managed some cases that I find interesting. This is an elective right lower lobectomy in a patient fit for surgery, no relevant problems, but an Al-Ganzouri score of 4 is a score for a difficult airway, but nothing really to be worried about, just a 4. So the resident prepared the operating room. These are the real average hemodynamic pattern of the patient. On the left, this is the baseline. She performed TCI anesthesia with propofol and remifentanil. These are the targets. She administered rocuronium, and then she went for the laryngoscopy. You can see the orotracheal intubation modification in hemodynamic pattern, so nothing really special, just a rise of a heart rate of 20%, blood pressure was stable, and she successfully intubated the second attempt. She reported difficulty routing of the tip of the double lumen tube. It's 41 French, so it's not so easy, but definitely not a problem. And this is our null trend, a clear rise in nociception during the laryngoscopy. Okay, then what happened? We put the patient inside position, and there is an evidence of air leak. The loop is not closed. We check the tracheal cuff that is broken. We have to change the tube on the same patient that felt pain at the first laryngoscopy. She asked for consultant supervision, it's me, a tube exchanger, and a video laryngoscopy. I know that it's not so adequate, the double lumen tube with the airway exchanger, but the real thing is that we raise the Minto target to 6 nanogram per milliliter, because at the previous intubation we had paid. So just give a look to the long procedure, laryngoscopy, then the suction of secretion, then we remove the double lumen tube. There is the tube exchanger in the left main bronchus, and once again, there are some problem with the routing of the tube, because probably is not the right management of this case. We change the hand, so a lot of time I try to rotate. At the end, I remove and use a different stylet to perform intubation. And this is the hemodynamic pattern. Okay, I rise with the Minto, with no hemodynamic, no hypotension, no modification in heart rate, and null was perfect, just rising 1 point. This was very interesting because it's difficult to make 2 laryngoscopy in the same patient. And if we talk about scientific evidence, a lot of targets for the TCI remifentanil are calculated with the up and down technique. So every triangle is a patient. If he feels pain, we try a higher dose. Otherwise, we go down. And so we describe these graphics with an AC95, an effective remifentanil dose to cover the laryngoscopy in 95% of patients, very high. In the double lumen tube is 9.9. Have you ever intubated a patient with a 9.9 remifentanil in TCI? So the risk of overtreat the patient with opioid is very high if we think in this way. Moreover, the studies about pain during laryngoscopy rely on hypertension and tachycardia that may be a reflex for epipharynx stimulation. So why don't we start to monitor in this way our laryngoscopy and our nociception during this maneuver? We can understand a lot of things, or try to define in another way the right target for the procedure. Same patient, side position, this time no air leak. We perform thoracic paravertebral block. Patient has not a so brilliant ultrasound anatomy, so on the dark blue, I perform a classical paravertebral block. On the light blue, we have to inject local anesthetic just above the costotransverse superior ligament. It's an approach less effective. Then we go for surgery. A surgeon put the trocar, okay, in different area that we are used to cover with the paravertebral analgesia, and on the lower medial trocar always have rise in during the scoping. Maybe there is pain in that area. This is the same patient. We used to inject methylene blue while performing the block to check the spread of the local anesthetic to prevent the uncovered area of analgesia. And the surgeon confirmed us that the spread of local anesthetic is stopped at the 6th interparavertebral space. Not enough. I'm lucky to rely on the methylene blue direct vision. Otherwise, I could rely on the null. The lower part of my analgesic plan is failed. And this is important because when we face severe postoperative pain, we don't know what there is inside our locoregional analgesia before the end of the surgery. We can imagine, we can think about, we can be worried, but there is a failure rate that is always present, even in ultrasound-guided procedure. And if I can anticipate and switch from A plan to B plan, I think it's better than run after the pain of our patient. There is evidence of topping the locoregional analgesia technique and improvement on the null pattern of the patient. Same thing in epidural analgesia. This was a particular case with the difficulty anamnesis due to cultural gap of the patient, no mediation, no sedation. The epidural positioning was more similar to a wrestling match than an anesthesiology procedure. I was not very sure of the right positioning of the epidural catheter. And this is in the light blue, the bolus of epidural, and you can see the null overview during the radical mastectomy, even at higher metamere. Everything was good, but what about if I learn about my technique failure after surgery? Mastectomy, chronic pain, a huge surgical field. I could think about playing plan B and C plan even. This is the patient, and the null confirmed the proper analgesic coverage, and this is the same paper shown cited. It can be useful to give you a feedback on a technique before it's too late. And this is the last case that gives some light on something we are not used to think about. Patient from surgery patient from ICU or patient in critical condition. We are always worried about the comorbidities, and we underdose the opioids because we are afraid of hypotension or impact of hemodynamics. This is a patient with acute respiratory failure after in COPD. She underwent tracheal intubation, then switched to tracheostomy. She had septic shock and a tracheoesophageal fistula that needed to be repaired because it was wider than 3 centimeters. This is our patient. The first null rise is at the tube manipulation and the first bronchoscopic inspection, nothing special. Then this is the phase in which you remove the tracheostomy tube and you put the cross-feed tube with the tube exchanger inside the surgical field. We have a severe desaturation, then the incision, but the hemodynamics didn't reveal us a high perception of pain if null didn't rise the index. So this is a practical example of how null changed our strategy during surgery. In the face of prosthesis positioning, patient experienced pain, nociception at the null, but give a look to the hemodynamics. Who could think that this patient was feeling pain, had a severe nociception, because it's hypotension cover any other possibility. And considering the hemodynamic status, we switched to ketamine analgesia intraoperative with a good response at the first of the post-administration time, but it was a difficulty patient to keep the proper analgesia. But at least we switched to another plan. We tried to change our approach. We don't just rely on the multi-parameter monitor, because this is a black hole of information about the pain in intensive care unit. This is an old paper 20 years ago, but there is no a lot of data about this issue because nobody wants to show his dirty clothes, but patients are always at risk of underdosage of opioids after surgery once in intensive care unit. And this is a problem very sensitive, especially in patients in coma that cannot communicate with us. In fact, we should think that the proper analgesia can help us in a lot of ways for an ICU patient, for the fighting of ventilator, for the delirium, the agitation, physiotherapy, hypoxia, all things that we never consider can be related to the pain after surgery. In fact, there are the first sign of attention to this topic because you cannot rely on vital sign during stay in ICU. You have to use technology measuring heart rate variability or different physiologic parameter to be sure your patient has not experienced nociception. So I give you my take-home message. Before turning on the monitor, you have to light up the knowledge about nociception, because if you are only looking for the magic number, you will not find it in the monitor. So spend the same time to get the best anti-nociception as the best ventilation. We are used to change our ventilator strategy during surgery. We try several parameters, several strategy, pressure, volume, respiratory rate, relying on the oxygen level. And it's not easy, but if it does not challenge you, it won't change you. Thank you.
Thank you very much, Dr. Rispoli. Do we have questions from the audience? I remember when they brought for the first time the NOL monitor to my hospital, we took it to the delivery room and we connected the patient before the epidural analgesia. First of all, we noted an extraordinary correlation between the uterine contractions, pain, and the VAS, the visual analog scale of the patient, and the NOL. And we could see immediately the result of the analgesia created by the epidural. But this is in an awake patient. When we started using NOL for the shoulder operations and we performed combined anesthesia, general with regional anesthesia with a peripheral block, we could see very clearly when the block started working. And so no need to wait for the end of the operation in order to know whether this block is acting correctly. So I know that no monitor alone by itself will change the outcome, but the combination of good monitoring with BIS and NOL has changed our practice in our hospital. For instance, when the nurses at the ENT department complained that the patient were having nausea and vomiting, using remifentanil for a couple of hours in long operations. So we started using NOL and we reduced by around 30% the dose of remifentanil with no changes in analgesia of the patient, and nausea and vomiting practically disappeared. So these are, in my opinion, the reasons why NOL is creating a kind of revolution. And maybe if we were missing this link monitor for analgesia, maybe I think we found finally the monitor that can help us in our daily practice. Would you like to comment on clinical use or postoperative pain, for instance?
Yeah, I like your comment and your remarks, and I really like the talks before as well. And I think we have to consider that we, as a pain physician, I like to talk to my patients and you in the, of course, in the PACU and everywhere we can do that. But we cannot do that in the OR. If we have a patient under anesthesia and we do not know what's happening. And if we have surrogates, and this is kind of a surrogate for nociception, and it gives us one number that's very, very easy to follow. It's, as you mentioned, has limitations. It has maybe some black box issues, but we have nothing else at the moment, and I think it's not that bad either, because we have now an idea of the nociceptive input. And I think that is, if you reduce opioids, if you have a hemodynamic stable patient, that it is what we want. So there are many, many arguments, and there are more to prove, like the long-term effects, that we use that. What's your idea about that?
Yes, I found the most interesting part of my null use just in testing the local regional analgesia. Because if there is not so strong evidence of a preemptive analgesia, intravenous preemptive analgesia, there is evidence of preventive local regional analgesia. If I'm sure that my technique is successful before surgical stimulus, my outcome will be better. And it's easy to understand when your technique fails if you have a dramatic failure, a primary failure. So you cannot execute the technique. But the secondary failure are everyday routine practice. There is no medical evidence, just a little paper about the secondary local regional technique failure. And it's up to our lack of formation. I found very interesting understanding with the useful time how is working my technique to plan the other alternative. The first use, the main use of this technique is for this, to give me a real-time feedback what I'm doing. Even with the precision of the metameric difference, if you remember the case of paravertebral block. Obviously, it's not always so clear, sometimes it's smoother, but as Professor told, we have a number to start with. Maybe it's not the perfect, but we have to start to think about nociception during all our surgery and to interrogate ourselves for the best strategy to use for that patient in advance for a preventive analgesia.
I fully agree with all of you. I think that we need to keep an eye on this. Another thing that's really important overall is we cannot forget that every patient has his or her own characteristics. So looking at the anti-nociceptive component is important, but I think looking at every component of anesthesia is important. We have the classic triad of unconsciousness, anti-nociception, and paralysis. But anesthesia is even more than that. There's also hemodynamic optimization. All these components of anesthesia, depending on the type of patient, are more or less important. In patients, for example, that are at risk of delirium, people that have a vulnerable brain, we need to really focus on the electroencephalogram. We need to make sure that we don't go into burst suppression. And probably coupling a good anti-nociceptive strategy is useful. In patients that are at risk of poor cerebral perfusion because their carotids are stenosed, we should probably have more of an approach of increasing perfusion of the brain, having a higher blood pressure, making sure that there's correct oxygenation. And I think the null can help us to simplify one of the components, keep the patient's own hemodynamics helping us, instead of having to artificially increase blood pressure with a vasopressor instead of and administer less drugs. And the other thing is that for every drug that exists in the world, there's a therapeutic dose and there's a toxic dose. Nothing is safe in medicine. Some drugs are more dangerous, like digoxin. It's a classical one with a very small difference between therapeutic and toxic, while others are more broad. But ultimately, if you give too much of a drug, you risk having negative effects. And if we look just at, for example, inhaled ethers or propofol, it's been shown you give a rat too much of these agents and you kill brain cells. So I really think that today, in 2022, we should start looking at the patient and making sure that we give the right amount and we don't just give arbitrary amounts that can be, for certain persons, too much.
Thank you very much. I think that the message when I started in my introduction saying that there is fast food anesthesia and there is Michelin stars of cooking when we are doing personalized anesthesia, the idea is that we don't have to use any more indirect parameters in order to decide whether our patients have pain. We can do a more personalized way of treating our patients. Thank you very much, and thank you for participating at this session.